record. So good afternoon, everyone. It's my pleasure to invite you to Elder Abuse Prevention Ontario's webinar on intersection between elder abuse and substance use disorders. I can't wait to hear Marilyn Campbell speak. So I'm just going to go through some housekeeping. For those who don't know, Elder Abuse Prevention Ontario is a provincial organization funded by the Ministry for Seniors and Accessibility. We just want an Ontario where all seniors can live free from abuse. And our main job is education and training and working in collaboration with partner organizations. All of you have been muted and we can't see you, so videos are off and you're all muted. The speakers will be visible and you'll see we have the wonderful Annette, Sandy, and Dean Weeb from sign language interpreters. So hopefully you can see them. You can also adjust the speaker image by dragging the line outside those squares on your screen. Please do share your insights, your experience, and in the chat box. So share your comments in the chat box. But if you have a question, questions go in the Q&A box so that we can just look at the Q&A box later when my boss, Rayanne Rideout, who is a director at Elder Abuse Prevention, she will be leading the question and answer session at the end. As I mentioned, the recording and slides will be on our website in a few days' time. After this webinar, you will get an evaluation survey, and we really want to encourage you to fill that out because we're always looking to improve and because our funder requires it. Please do, when you ask questions, please keep them general. We really want to respect people's privacy and confidentiality. So I want to pay my respects to the land that I am working and residing on. At Elder Abuse Prevention Ontario, we acknowledge that we are on the traditional territory of a number of First Nations, and we acknowledge their stewardship of this land throughout the ages. We seek a new relationship with the original peoples of the land, one that is based on honor and respect. So this presentation today is on a very important topic, elder abuse and substance use disorders happening at the same time. And you all know how difficult this is. So these are the objectives. Marilyn is actually going to go through them. So I'm going to just move on to introduce Marilyn to you. If you don't already know her, you should, because Marilyn is a recognized pioneer in the field of geriatric addictions. She is a clinical, so Marilyn Campbell is a clinical geriatric addiction specialist with Baycrest Long-Term Care Behavioral Support Outreach, BSO, teams. She is the provincial lead for BSO Brain Exchange Older Adult Substance Use Collaborative. And Marilyn has recently launched Cannabis and Older Adults, Know the Facts. She's also a co-investigator with the Canadian Coalition for Seniors Mental Health. That coalition established 4 national clinical best practice guidelines for substance use disorders in older adults, including alcohol, benzodiazepines, cannabis, and opiates. Marilyn is co-chair of the Alcohol Working Group. She is the recipient of the Ontario Psychiatric Award of Excellence and recipient of the inaugural 2018 Seniors Mental Health Outstanding Care and Integrative Practice Award. And that was given from the Canadian Academy of Geriatric Psychiatry and the Canadian Coalition for Seniors Mental Health. So with over 35 years of clinical experience working with older adults with substance use disorders, you can see that Marilyn is the best person to be speaking on this topic. And I'm so glad and grateful for your time, Marilyn, with us today. So go ahead, Marilyn, you take over and share your slides.
Marilyn, you have to unmute yourself.
Can you hear me now? Can you hear me now?
Yes, yes, Marilyn.
Okay, okay, good. So, to understand the addiction as a disease and sort of the neurobiology behind addiction and the late life differences in older adults with substance use disorders. And I particularly wanted to look at some of the strategies for families and caregivers for appropriate enabling when there's a problem substance use with older adults, and look at that connection between substance misuse and elder abuse. So why is geriatric addictions a problem? So we know that older adults have a greater risk for falls and delirium. There's a connection between suicide in older adults, and that's a predictor of suicide risk. It is linked to cancer, liver disease, stroke, cardiovascular disease. We don't often hear about that, but alcohol is a carcinogen. Many years ago, when the tobacco industry was, when smoking was sort of mainstream, it came to the public that it is a carcinogen, and actually there's many links to different cancers from alcohol, and it's not as mainstream as we know tobacco to be. So, but globally, alcohol was linked over to 3 million deaths per year, slightly more than lung cancer and HIV combined. So the mortality rate is very high. So it's in proportion to other substances, it rates about the second after lung cancer. So in terms of proportion of substance use and disorders in long-term care, it ranges from 23% to 45%. So similarly with the geriatric inpatient population, patients admitted to psychiatric units, the rates were about 11.7%. The most commonly used substance is alcohol, and that accounts for about 73.3%. And other substance use disorders that were found included sedative hypnotics, opiates, cannabis, and tobacco. And when you look at the prevalence of substance use disorders, we see that the rates for abuse and dependence is around 11%, for opiate abuse and dependence 2.9, cannabis use 1%, and tobacco use disorder 1.4%. So I just want to get a feel from the audience about your views on addiction. Is it a personal choice? Is it something else? So I'm going to launch this poll. Okay, can we ask you to vote?
So Marilyn, it's just Christine here.
Yeah.
If you just go to polls at the bottom and click it, and then launch it.
Polls. No, it's not allowing me to do that. Oh, I see. Action is relaunch polls. Okay.
Thank you. Yes, perfect.
Okay. So if you could just vote, is it a personal choice?
Yep, it's running. Thank you, Marilyn.
Yeah, good. Thank you. Okay, I think we've got most people that have voted, so I'm going to end the poll. And we see that that about 15% of you think that that addiction is a personal choice, and about 85% of you say no, that it's not a personal choice. So so thank you for that. So I'm going to move on and talk to you about some of the reasons why it's there's some stigma around addiction. So In terms of the use of substances, there's some beneficial uses to different substances. I don't know if any of you right now are having a coffee or a tea. That is something that's got caffeine in it, may give you a little bit of a boost, sort of, you know, positive effects in terms of your alertness. And then there may be some benefits to moderate consumption of wine. And then there's the sacramental use of ayahuasca or peyote. And then there are other non-problematic uses, so recreational use or casual use of a substance that really doesn't have any negligible, it has negligible health or social effects. But when you get into the problematic use, that's when those negative effects or consequences for individual and family start to show up. So for instance, impaired driving, binge consumption, and harmful routes of administration. So, and then on the other side, there's the chronic dependence use, which has become habitual and compulsive despite those negative health and social effects. So again, when we look at the substance use, there is a lot of moralizing when it comes to addiction. So I asked you, is it personal choice? There is a lot of moralizing. Addiction is really not a moral failure. It is a disease which needs support and treatment. There are some people that will pick up a drink and have a drink and never run into problems, but then other people will. But we know that the substance reacts on the reward pathway of the brain. So alcohol, cocaine, even nicotine, cannabis, benzodiazepines, they react on the pathway, reward pathway. So it is a chronic disease of the brain. It's a disease because the drugs modify that chemistry and structure of the cells and those circuits involved with reward, motivation, and memory. So in the addictive brain, the drugs hijack that normal learning, those pathways, and they activate those reward circuits in response to drug-associated cues, which leads to cravings and compulsive behaviors and compulsive drug-seeking behaviors despite the harmful consequences. The clinical significance of these brain changes is that the addiction, once it's established, becomes chronic in nature and has relapses and remissions. So like diabetes, cancer, heart disease, addiction is caused by a combination of behavioral, psychological, and environmental and biological factors. Genetics, it certainly is a risk factor and account for about half of the likelihood that an individual will develop an addiction. But it does involve changes in the functioning of the brain and the body due to the persistent use of things like nicotine, alcohol, and other substances. Nicotine is one of the most addictive substances, even more so than heroin. The consequences of untreated addiction often include other physical and mental health disorders that may require medical attention if they're not treated. And over time, the addiction becomes more and more severe, disabling, and life-threatening. And of course, in older adults, at the end of life, it becomes so much more disabling.
And
So
Marilyn,
again,
it's just Christine here. I've got a note in the chat box to say people are enjoying your presentation. They'd love for you to slow down just a little bit so that they can take it in.
Okay, thank you. So if you look at opiates and the action on the brain, so opiates react on the brain and the nervous system. It can change the brainstem area that controls automatic body functions and depresses breathing. So if you think about that, you know, that's a risk factor for older adults. Opiates can block pain messages transmitted by the spinal cord to the body, so it's a positive thing. But these other more negative consequences, it can change the limbic system, which controls emotions, to increase the feelings of pleasure. So again, the brain really plays an important role in addiction. And it's not like people with addictions choose to use drugs. The idea that people with addictions choose to use drugs does not make it less of a disease. There's many chronic diseases that originate with voluntary lifestyle choices. Like COPD, diabetes, hypertension, cardiac disease. And in no other disease that we see in medicine does the patient get told to go away, treat their addiction, and then come back and we'll treat you. And if someone was walked in and said, with hypertension, with cardiac issues, you get medication right away, despite the fact that you might be eating chicken wings and pizza every day, making not very good lifestyle choices. But with people with addictions, there is a systemic there's systemic stigma, and people are assumed to have made this choice. So while the initial choice to use drugs or alcohol may have been voluntary at first, the changes in the brain make it very, very difficult for the addicted brain to voluntarily stop using. So for those of you who are clinicians out there, these are the criteria for substance use disorders. Maladaptive use leading to stress or impairment over 2 to 12 months, and criteria 4 is loss of control or compulsion, so using more or larger amounts than intended, persistent desire to cut down or stop, increased time devoted to using or recovering. And this is the game changer, and this is the thing that's different in the DSM-5 now, and that's the cravings and the urges. And why that's important is because we do now have drugs to treat those cravings and urges. So some of the negative consequences: failure to fulfill major roles or obligations, use despite social problems, and important social or occupational or recreational activities are given up. And for older adults, the threshold's a little bit different because they may not have social obligations. They don't have jobs that they may be involved with. So the threshold may be a little bit lower to identify an older adult. So there may be risky use and situations where it might be physically hazardous despite health problems. And for older adults, they're more likely to have some health problems with chronic use. There is criteria for physiological dependence, so tolerance. So it takes an increased amount to achieve intoxication or desired effect, and diminished effect with the use of the same amount. However, with older adults, it takes a lot less of the substance for the person to become intoxicated or impaired. The other criteria is around withdrawal, that when the person stops using the substance, they may have a withdrawal syndrome, or they may have to take more of the substance to relieve or avoid withdrawal. So alcohol and prescription drug use in older adults is at about 17%.
Marilyn, sorry, it's just Christine again. I just want to check with Dean. Dean, how's the pace of is it okay for you with interpreting?
It's better. We could still slow down. We could stand to slow down a little bit more. That would be helpful. Thank you.
Thanks, Marilyn. Marilyn is so interesting,
Okay.
but even my brain is, I want to take it all in. It's a lot of information and it's so good. So continue.
Okay. So we know that it's overlooked in geriatrics and addictions literature, and there are many barriers to identifying substance use disorders in older adults. Again, these are things that you would typically see in older adults: confusion, falls, sleep disturbances, failure to thrive, self-care issues. These mimic other conditions. And there is also ageism to think about, and people often think, well, why give up their last remaining pleasure? It's the only thing that makes them happy. It's less likely to be detected in females, and we see that females and higher educated older adults have higher substance use issues. And there's also a lack of age-appropriate screening tools in the research. But in terms of the tolerance for alcohol, we know with physiological aging, there's a reduction in the proportion of body water, resulting in increased potency of alcohol for seniors. So, and in particular, there is a greater susceptibility for women. Women have more body fat than men. Men have more muscle mass, so women become intoxicated at a higher rate. And slower metabolism results in those prolonged effects in the central nervous system. In terms of depression and suicide with alcohol use disorder, there's a strong link between suicide, alcoholism, and depression. It increases where there's an alcohol use disorder, and the lifetime risk in the general population is about 1%. With older adults, that rises to about 15% of people with depression and 15% of those with alcohol use disorder. So the key message here is that you need to treat concurrently to look at depression and alcohol use disorder. If you treat both the depression and the substance use in older adults, it leads to marked reductions in psychiatric hospital stays. In terms of substance use disorders, there's early onset drinkers. Those are the people who have used alcohol throughout their lifespan, and now in later life, and actually even in their early 50s, mid 50s, start to have many health issues as a result of their chronic use. The late onset drinkers are the people who start to drink in response to retirement, poor coping skills, different vulnerabilities around grief, health issues, lots of changes associated with late onset drinkers that they don't cope quite so well. There are risk factors, and for elder abuse due to isolation, loneliness, and other vulnerabilities. So when people are alone, when they're not, when they're isolated, it's easy to become to be someone who's susceptible to elder abuse. There's also discrimination and stigma associated in terms of admissions to long-term care. So the chronic use, early onset chronic use, older adult generally ends up in long-term care at an earlier age. People with substance use disorders have a difficult time even getting into long-term care because there is a lack of understanding on how to support. And so not all facilities are able to or are willing to accept an older adult where there's a substance use issue. So alcohol is different in the geriatric population than it is in youth. It's not broken down. It goes by the liver, it goes to the rest of the body, including the brain. It can affect the part of the brain that control movement, speech, judgment, and memory. And these effects lead to signs of intoxication. And again, remember, these things can be mimicked by other illnesses that and diseases that older adults have. So they may have difficulty walking, slurred speech, memory lapses, and impulsive behaviors. Long-term alcohol use can shrink the frontal lobes of the brain, which impairs the thinking. One of the things that we want to make sure the messaging around for older adults around low risk drinking is really an important thing, because these are guidelines that have never been written for older adults and we looked at this very, very carefully in terms of how do we support and encourage older adults to stick to low risk drinking guidelines. And there's a fair bit of science behind it. So we looked at the quality and the type of substance in addition to quantity and frequency. And in Canada, for the general population, so many of you who are in the audience fit that criteria, a standard drink of alcohol contains 13.6 grams or 7 milliliters of absolute alcohol, and or the amount that's contained in a beer. So that's 12 ounces or 341 milliliters of beer, 5 ounces of table wine, or 1.5 ounces of hard liquor. So that's a standard drink. So when you think about it, these are all the same. So a beer, a 12-ounce bottle of beer, a glass of wine, 5 ounces, or 1.5 ounces of hard liquor. Because oftentimes we hear people say, well, I only drink wine. It's not the same as drinking hard liquor, or I only drink beer. It's not the same as drinking wine. But when you look at the per volume differences, these are all the same. So these are all a standard drink. So what we mean by low risk for older adults is that no more than 7 standard drinks per week for men, and no more than 5 standard drinks for women with 2 non-drinking days. So that is a low risk amount of alcohol that would ensure that the health risks are not, that drinking does not become a health risk for the person. And the other recommendation we made in the guidelines is that we suggest that if the person has multiple medications, comorbid health issues, falls, risk, etc., that there should be no alcohol used. And we also know that some people at age 65 or at 70 are in very, very good health. They ride, they cycle, they canoe, they hike. They may be someone that can tolerate the usual standard drinks for the general population. But we know that for some older people, they may need to transition to 0 at an earlier age because of those frailties. So this is an infographic that you'll find on the CCSA website. These are the low risk drinking guidelines. If you want to download them, I've included that at the end of the slides. So what are your views about stopping use of alcohol or drugs? Does a person have to want to stop using alcohol or drugs in order to get help? I'm going to open the poll.
So Marilyn, you've clicked the poll at the bottom, the polls.
Okay, so it's this one. Okay.
Perfect.
So a person has to want to stop using alcohol in order to get help. Well, looks like we're a little bit divided here. Let's give you a few more minutes, a few more seconds. 15 seconds, okay. So I'm going to end the poll. So it looks like it's a 50-50 split. So so people are thinking that most people need to want to stop using alcohol in order to get help. Well, the reality is there are some other, people, when there's dementia, how can you really make informed choices? How do you understand and appreciate that your substance use is really interfering with your life? And, and oftentimes the suggestion from healthcare providers is that maybe you should go to an AA meeting, maybe you should go to treatment, you need to stop drinking. But if you're asking someone to change where there's dementia or cognitive impairment, or they've got a brain injury from multiple falls and their executive function is not as they're not as able to make good choices, you're asking the person to change, but they don't really remember what they're asking you to change. So keep that in mind. What is the good news is that treatment for older adults works well in spite of, asking people to make changes. You don't necessarily have to, the person doesn't have to admit that they have a problem in order to get help. They don't have to admit to a problem in order to make meaningful change. If they are someone that is interested in making change and they have they're relatively well, they can certainly attend and participate in mainstream programs. But for older adults that have frailties, cognitive impairment, you still can work with them very, very well in spite of that person not admitting that they have a problem. So there is also pharmacotherapy that's available. And again, that's the game changer I spoke to in terms of the DSM-5 criteria around the craving. So the anti-craving medication for alcohol use disorder is really, really well tolerated in older adults. Naltrexone is the drug that is used that is first line for older adults. There is also good news in the reversibility of Wernicke-Korsakoff syndrome. So when people abstain from alcohol, they have good medical care, good nutrition, some of that memory, some of their balance issues, those things can be reversed again, but that's based on abstinence. And someone who doesn't understand and appreciate that, the need for abstinence, they may end up in a care situation because they need to have medical care and support and nutrition to see any benefits. And in some cases, it's too late for some older adults. Certainly, harm reduction can reduce the risks and harms associated with substance use. So harm reduction, we know that cutting down or stopping the substance can make all the difference. So alcohol, we know, can cause damage to the brain. It goes to two places. It goes to the liver or to the brain, and it can increase the risks of all types of dementia. And people with alcohol use disorder perform worse than controls in cognitive testing, but better than people with Alzheimer's. So if you look at and have someone who has an alcohol-related brain disease and they abstain, it does foster stability in cognitive-induced cognitive impairment, in alcohol-induced cognitive impairment, and there is a possibility of improvement. And we certainly need to have more research in this area. But the cognitive decline has been, in terms of other dementias, it's suggested that the decline in cognitive or physical functioning in alcohol-related dementias is relatively non-progressive in abstinent ex-drinkers and is even partially reversible. And that's supported by imaging studies. So you can actually see the changes in the brain. So that's kind of the good news. With Alzheimer's disease, there's a very much a downward trajectory, whereas there's a leveling off in terms of an alcohol-related dementia once abstinence is achieved. And oftentimes we see improvements for people who enter into long-term care situations. So elder abuse and substance use, what's that connection? So there are many, many vulnerabilities. If the person is physically dependent on alcohol use or other substances, and they're not well enough to go out to get it, then sometimes there is a need to rely on people to help with the supply. And we'll talk about the enabling factor later on. But there is a great deal of stigma. What we see often is, especially for men, is financial exploitation. Whereas for women, more psychological and physical abuse. So in terms of alcohol and physical dependence, So if you have someone who is dependent on alcohol, when they stop using it, we know that alcohol withdrawal occurs within 8 to 12 hours after the last drink. So if you're the person that, or the family members are supplying the alcohol, and the person is physically dependent and they don't have their alcohol the next day, they may end up in severe withdrawal. And there can be serious complications such as hallucinations, seizures, and delirium. And those are serious. They need and require medical attention. In terms of medications, are the medications being monitored? And we know with older adults, they're more likely to be prescribed benzodiazepines and more likely to be prescribed opiates for pain. Are the medications being stored in a safe place? Is the person being undertreated or overtreated for pain? And sometimes the undertreatment can happen when somebody else is using the medication. So is there a risk for diversion? So are the medications being used, but the patient is still, or the person is still being complaining of pain and not getting not getting proper treatment because the medication is not being taken by that person, that somebody else has diverted the medication. Are the medications used for the purposes other than prescribed? So again, opiates, and the risk for diversion of opiates is fairly high. And we know that young people, they often get their first trial of opiates from the dentist, although the numbers are sort of going down now with better prescribing practices. But then the next is going to the parents or the grandparents' medicine cupboard.
Marilyn, just letting you know, 10 minutes to go, but all good
Okay.
information.
So enabling. Okay, so the enabling factor. So enabling refers to a positive act of helping someone to accomplish something that they couldn't do alone. So how do we support an older adult that has a substance use disorder? But there's also an act that refers to helping someone in such a way that rather than resolving a problem, it in fact is being perpetuated. And there is a fine line between appropriate and inappropriate enabling. So the number one thing that I see is that purchasing of alcohol. So if you have someone at home or in long-term care and they have dementia and family members are bringing it in, I've seen people smuggling it into shampoo bottles and bringing it into long-term care. Is the person with dementia, are they able to get out to get it? Not likely. So if they can't get out to get it or to buy it, why would you bring it in? So and the other thing is, the other side of the coin is, do you go out and you buy it because you don't want mom or dad to drive while they're intoxicated? So there's the difference, appropriate versus inappropriate enabling. The other is buying street drugs when the person runs out of their medications. And I always ask the question, do you know what's in that bag? Do you know that that you're really getting the opiates? Are you getting hydromorphone? There's a lot of drugs out there that are tainted with other drugs. There's purple fentanyl. The rates of overdose in the community has skyrocketed through the pandemic. We've lost over 2,000 young people to opiate overdoses during the pandemic. So if someone is buying medications, over the fence, over the counter, over the fence, you need to be aware of what's being purchased. And the one issue that caregivers and personal support workers have is in terms of the fall. So what do I do if the person is intoxicated and they fall? And oftentimes I hear, oh, I picked him up and I put him back to bed. Well, we don't know whether or not the person fell because they had a seizure. We don't know if they fell and hit their head. We don't know if they fell if they sort of slid down and were unconscious. Are they have they taken some other drugs? So it's not the best practice to just pick somebody up and put them back to bed. You want to make sure that they get checked out medically, even if they're not asking and they're saying, please don't call the ambulance. It's good to have them checked out to make sure they didn't break anything. And sometimes they do need to go to hospital. They may have had a seizure. The other is around spending money on alcohol, but not making financial commitments. So if the person has a POA for finances, if a caregiver has a power of attorney for finances, making sure that there's always food in the house, that the person's needs are met, and that there is alcohol present, but not enough to cause risk or harm. So always asking the question, are you helping or hindering, especially alcohol delivery systems? And I have seen many, many situations where the alcohol delivery system, the alcohol dial-a-bottle people have come in, they buy the alcohol for the person, the person may give them $100 and the alcohol is, $32, and then there's no change left over. Or the person comes in and helps themselves to the jewelry or other possessions of the older adult because they know they're intoxicated. The other is friends that show up when the pet check arrives, that at the beginning of the month that the person is financially taken advantage of. Lots of drinking buddies but when it comes time for the person to need groceries or assistance to go to the doctor, there's nobody there to support. So are they helping or are they hindering? Using credit cards or debit cards, sharing of PINs. I've seen even people with dementia going to bars and they just hand over their cards to the bartender, and huge sums of money are taken from the debit card on a daily basis. And so there's a great risk there for a vulnerable older adult when they share their debit cards or PINs. So again, often financial exploitation is fairly common, misusing power of attorney for finances, not ensuring that there's adequate nutrition, making sure that the vendors, for instance, exploiting if they're helping themselves to higher than usual tips and so on. And what do you do when the person demands alcohol and you're the power of attorney for finances? How do you politely decline? That's a really hard one. And sometimes I say to family members, when that power of attorney becomes too much of a burden, if mom or dad is, they're really, it's straining the relationship, then sometimes you have to hand over the POA for finances to someone else so that you could be a family member instead of, a family member instead of a banker, because that's often the gateway to the substance use. And so a public guardian and trustee, for instance, can set some limits and say, okay, well, I'm going to give this amount of money on a weekly basis, not all at once. We'll taper it out through the week so that the person has $10 or $20 on Monday, another 10 or 20 on Wednesday, and then a little bit more on the weekend. So being mindful that financial exploitation can occur and does occur with older adults. If you want to support the person, if abstinence is not desired, you need to look at harm reduction approaches. And certainly if there's dementia or risky substance use, such as risk for falls, fires, leaving things on the stove, losing money, or driving while impaired, those are under the influence, those are areas of concern. So you want to look at helping to reduce the risks and reducing the harms. And so that may mean helping the person to reduce their drinking by slowly, and you see that's in caps, slowly tapering to ensure that withdrawal is not precipitated. You don't want to stop suddenly and abruptly and put the person into withdrawal. A nice thing that we see now is that a lot of de-alcoholized beverages are out there on the market, and they actually look and taste very much like the real deal. And I use that quite regularly with people who have dementia, and you want to make sure it is a slow taper. So switching out one standard drink a week with one de-alcoholized to make sure that they don't go into withdrawal. You also want to make sure that the person is safe from predatory relationships, and that's why sometimes the POA for finances is an important role to make sure that people are not preying on the older adult and getting access to their cards and their funds, their savings. The other is around ensuring a safe transition to long-term care. If the person does need to go to long-term care, you want to make sure that there's a well-developed transition plan. And that may mean slowly tapering or having a medically supported withdrawal for the person. Just quickly about cannabis. With cannabis, it can be a friend or a foe. Does the person know the content type of cannabis that they're purchasing? And oftentimes I find older adults, they may have tried it in the 60s, but they don't know how potent it is now. So there's, do they know what the THC or the CBD content is? Those are two very different types of strains of cannabis. So one is the THC has psychoactive components, and CBD, there's no psychoactive component. It can be smoked, vaped, or ingested. And the important thing, especially for older adults, is that the time of onset of action, so for the time you smoke it or you ingest it or you vape it, it takes a little bit of time to process. So oftentimes people end up having overdose situations or become toxic, especially with edibles. And the other thing is that some of the street drugs, so if you buy cannabis from a dealer and you're not sure who it is, sometimes those drugs are, the cannabis is laced with fentanyl and benzos. So there are also diversion risks. So if mom or dad have cannabis prescribed for cancer care and or they have it, they're using cannabis for pain relief, there's a risk also of young people coming in or other people accessing the supply. So we always suggest that older adults keep it locked up. The one issue that we want to make sure that older adults are aware of is that when you're taking cannabis, that you can and do get high and you become intoxicated, and you can be charged with driving while under the influence. It takes a lot less cannabis to get an older adult high, and it also has takes a longer period of time for that for it to reach the system. So sometimes people will take an edible, and they'll think, well, gee whiz, I had a bite of this cookie and it really didn't do anything for me, so I'll have some more. When actually the prescribed amount might be a quarter of the cookie. But we're seeing older adults eating the whole cookie and ending up in the emergency department because they're psychotic. So older adults are very different in terms of tolerance. So we need to encourage them to start low and go slow. So here's the fact sheet that you can download that from the Brain Exchange website. We also have for download the guidelines. So the 4 guidelines for substance use disorders: benzos, opiates, cannabis, and alcohol. You could download those from the Canadian Coalition for Seniors Mental Health. And here's some links for providers. Addiction medicine services are available throughout the city of Toronto associated with them. And that's where a person who has a substance use disorder can go anytime without a booked appointment. You just show up and you'll get some support from an addiction medicine specialist. So these are some other resources, and the rapid access addiction medicine clinics in Toronto. If you click on that Medify site, you will see that you can access addiction medicine clinics all over the province. These are some resources for caregivers. So if you have an older adult that lives in the city of Toronto, there's Reconnect Mental Health Services. The COPA program does outreach to older adults with substance use disorders. And again, for each of the guidelines, there are some handouts for caregivers, for older adults, for alcohol, opiates, benzos, etc. Okay, so I'm about 10 minutes in. We've got about 10 minutes for questions.
Yep, just a reminder, if anybody has questions, that they can post those in the question and answer box. We do have one question, Marilyn. And the first one is, what does harmful routes of administration mean?
Okay, so that may mean, for instance, somebody who is needing to inject a substance. So if they're using opiates, and instead of taking them orally, they're starting to cook them and inject them. Does that make sense?
Yep, thank you. I don't
Okay.
see any other questions at this time. Does anybody else have anything that they would like to post? I don't think I've missed anything. It's been great comments and suggestions, and people post some links to some resources in the chat box. It's informing people that where they can get further information, and we'll post the webinar as indicated in the slides, because there's a lot of information within each of those slides that you've discussed really well for people to access within the next couple of days.
I see that there's one for Active Aging Canada. They have a project on cannabis and older adults. I was part of that group as well. So yes, you can download that from Active Aging Canada. It's a great booklet, and it is available in multiple languages. I think they've got about 12 different languages, and they can mail them out to you.
There's a question that was just posted from Constance. If an older adult or parent is in denial of having a substance use disorder, can I go as a POA to get a person help?
Can you get them help? I mean, certainly as a substitute, if there was a determination of incapacity and the person is not able to consent to healthcare decisions, getting treatment is a healthcare decision. Can you force somebody to go to treatment? The reality is that any treatment program, they still have to, for any residential treatment program, they still have to be able to understand and appreciate and participate in the program. So it's not the answer to for someone who has cognitive impairment. If the person has, if they're cognitively impaired, you can certainly speak to your healthcare provider and look at some options, such as using pharmacotherapy. So, looking at anti-craving medications. You can access rapid access addiction medicine programs. It's a really low barrier program, and once people get into a rapid access addiction medicine program, oftentimes, again, because they're really they're there to help, and they don't ask you, do you want to stop drinking? They say, do you want to feel better? So many of the clinics are low barrier, and they can help with switching people over from opiates to Suboxone or buprenorphine, which is less likely to be diverted. It still is diverted, but it may be a safer choice.
Great, thank you.
So, but overall, you can't sort of force anybody into treatment, and it's more because of their ability to understand and appreciate and participate in the programs. So there's other low barrier. That's where I would go, is looking at low barrier programs as opposed to sort of the residential treatment. So what
I just had a
resources-
question, Marilyn, are there like wait lists to get access into treatment programs, or even, and do they still or have on-site residential programs for older adults? I know years ago they used to, but I'm not sure if that still exists.
Yeah,
at this time.
they in Ontario we had one program, and that was the Homewood program, and that no longer exists. Again, if somebody is well enough to go to a residential treatment program, then they don't usually need older adult specific. What tends to happen though is that when they go, they feel like, you know, they're the grandpa in a kid's party kind of thing. So because the population that is in the program may have different needs than the older adults. So yeah, so there is waiting lists because of the pandemic. A lot of the programs are not admitting people, or they are. It's, you know, it's very long waiting lists. So yeah,
Okay.
it's not. And I think, you know, outpatient is and using RAM clinics is probably a better route to go for older adults, and many of them are doing virtual now, so that's a bonus for older adults. And I see most of the people from the community and long-term care virtually.
Okay.
So resources to have discussions with older adults. Just to having the conversation. Well, I would go to the CCMH website and download those pamphlets. There's pamphlets for opiates, cannabis, alcohol, and benzos, and it gives you some tips on how to start the conversation. And it should never be, you know, your drinking is really getting out of control, and I need you to stop. The conversation should be, I'm concerned, you know, what the alcohol is doing to you these days, because you've been falling more than, you know, lately, or you're not eating as well. And I'm kind of concerned, is there a way that we can support you to help you to cut down on your drinking, so that you can make some healthier choices, and that you can stay in the community a bit longer.
Thanks, Marilyn. I'm going to now turn it over to Christine to finish the slides as we wrap up the session today. So thank you again, Marilyn, and our interpreters for joining us, and everyone today who's joined the webinar and gave us great comments. And Christine, you can do the ending.
Thank you, Ryan. So wonderful. And you know, Marilyn, I'm going to be downloading the Cannabis Know Your Facts sheet and the other guidelines as well. Thank you so much. We will have an evaluation survey that will pop up on your screen. So please take the time to complete it. We'd really appreciate it. And our funder requires it. Stay in contact with us. We are on all the social media platforms. And here is my phone number and email address. And I think we're done. So thank you so much, everyone. And also a big thank you to Annette and Dean, our wonderful sign language interpreters. And Marilyn, thank you for your kindness and your generosity in sharing your wisdom with us.
Just a reminder, on Sunday is World Mental Health Awareness Day. So that's a UN initiative. So people, if you're not, if you would like to engage in that conversation, we can send out other resources that we'll be posting on our Facebook and social media pages around that event as well. So thank you. And if we look forward to you joining us next week for our next webinar that I posted as well. And that's looking at supporting 2S LGBTQI people living with dementia and unpaid caregivers. And we have another session the following week on MAID, looking at the medical assistance in dying session as well on the 19th. So more to come, and stay tuned. Thank you so much for joining me.
Thanks, everyone. Have a wonderful afternoon. Marilyn, you wanted to say something?
Oh, I just, we have geriatric addiction rounds once a month. And so if you want to join our geriatric addiction rounds, it's a lunch and learn the second Tuesday of the month. You can send me an email and I'll get you on the email list.
Oh, wow, that's wonderful. Thank you. Okay, bye, everyone.
Okay, bye-bye now.